Hello everyone, it's time. Thank you to be here today in this new webinar of Septodont. Our Septodont team is also very happy to welcome Dr. Yepes. Dr. Yepes, thank you so much for your participation. Thank you for sharing your experience with us. So we will have around 45 minutes to 55 minutes of lecture, followed by 15 minutes of questions. The mics are in mute, so please use the chat, and we will answer to all of our questions at the end of the lecture. The webinar will be recorded, so we will send you the link within 48 hours. Thank you again, Dr. Yepes, for your lecture today, and the stage is yours.
Okay, I want to thank you, Emily, and I want to thank you all my colleagues who are taking the time to, away. I know we are in different time zones, and some of you are taking some time away from your families, and some of you are taking away time from your practices, and I really appreciate that. Definitely, these times with the coronavirus around us, it really changed a lot. It really changed our lives. No matter what you do, no matter what you are, or in which country you are, really the coronavirus changed many, many different things in our lives. One of the things that changed in my life for sure is the use of technology to communicate and the use of technology to present webinars. I think so. We never imagined that we will be giving so many webinars and so many lectures online, which honestly, I'm glad that we have the technology to do that. I want to thank you, Septodont, deeply thank you, and thank you, Emily, for this invitation. This is a very interesting topic, and it's very appropriate for these times of the coronavirus. So I'm sure wherever you are, just relax. If you are in a time zone that you are in the morning, go ahead and bring a cup of coffee. If you are in a time zone that you are in the afternoon, well, you can also have a cup of coffee. And if you are in a time zone that you are in the middle of the night, so don't have a cup of coffee, because I don't want you to stay awake the whole night. We are going to learn, and that's my main goal. I have about 45 to 55 minutes lecture, and then we are going to have some time for questions and answers. And I hope that you enjoy. I hope that you learn something. I hope that when you close your computer, you feel like, okay, it was worth it to listen to this guy, and I learned something. So I'm going to close my camera so you don't see me anymore. And the PowerPoint is ready. And Emily is going to tell me if there's any technical issues, because sometimes, as you can imagine, sometimes we have some technical issues. So Emily will be ready to tell me if something happened. I'm going to turn off my camera, and I'm going to pause for about 10 seconds. That will be the time that you need to sit down, breathe, make sure that your oxygen saturation is above 96%, and check your temperature before you do this webinar to make sure that you feel good. So I'm going to take out my camera, and I will give you 10 seconds. Okay, so we are going to start. And so the title of this webinar is Minimally Invasive Therapy. And for now, I'm going to use IRT, but we are going to exchange that for also ATR. We are going to learn what is the meaning of these procedures. We are going to discuss that in a minute. And I will place special considerations about how to use Biodentine. I have been using Biodentine for a while, and I love it. So I'm going to share some of my experience and some of my cases that I have been using Biodentine. So a little bit about me. I am a professor in the Department of Pediatric Dentistry at Indiana University School of Dentistry. I work in a children's hospital, Riley, which is located downtown Indianapolis in the state of Indiana in the United States. Just to give you some kind of location, if you are outside the United States, we are in the middle of the US. We are about 3 hours driving southeast from Chicago. So if you think about Chicago, Indianapolis is about 2 hours and 45 minutes, 3 hours, depending where you are driving from Chicago. So that's me. This is the kind of the summary of what we are going to learn in this webinar. So the idea with this webinar is to provide the necessary background and the knowledge to understand minimally invasive restorative dentistry and the applications of Biodentine. As you can imagine, this topic is absolutely critical. I mean, I cannot emphasize that more during these days of global pandemic because of SARS-CoV-2. And by the way, I hope that you are doing well, that your family is doing well. Again, this is something that we never imagined will happen to us, and it's difficult for everybody, and we are kind of learning how to adapt. And more important, we are learning how to live for a while with this virus. So this webinar will, as you know, the use of aerosols in dentistry must be minimized as much as we can. And minimal invasive restorative dentistry is an effective way to provide high quality care with the minimal productions of aerosols. So minimal invasive therapy or minimal invasive dentistry is a way to provide care without using the aerosols, or I don't want to say without, or just telling you don't use it, with a minimal use. We can use other techniques when we can limit the amount of aerosols. So this webinar will discuss in detail the indications of Biodentine technique and within the frame of minimally invasive therapy. In all my webinars, if this is not your first webinar with me, I hope that you are not sitting there and saying again the same slide. But believe me, I need to put this slide always. You know, I need to remind myself that I need to honor the dentists who were sitting in this office before me, and especially Dr. McDonald, which, as I said many times in previous webinars, Dr. McDonald is one of the iconic heroes of pediatric dentistry in history here in the United States. Dr. McDonald was the dean of our dental school here in Indiana. And also he, as a pediatric dentist, the main author of McDonald Dentistry for the Child and Adolescent, that, by the way, we are working in the 11th edition, which is an honor to work in here at Indiana University with my colleagues, which in fall of 2020 or spring of 2021, the 11th edition will be out. So these are the learning goals for this webinar. We are going to the potential risk. That will be the first part of my webinar of using aerosols in dentistry, especially in the frame of the current situation of the coronavirus. I want you to become familiar with different non-aerosol generating restorative procedures. We are going to understand the indications and criteria for the ITR or ART, and we are going to define that later in the webinar. We are going to learn the most updated information about the outcomes of these two techniques, which basically they are the same. There is a difference, and we are going to learn what is the difference between ITR and ART. We are going to learn. So I'm looking at your eyes right now, and at the end of the webinar, I will be looking at your eyes and I will ask you what is the difference. But for now, let's kind of exchange both terms, ITR and ART. And I want you to become more familiar with the materials that we have for the ITR or the ART or atraumatic restorative technique. I have an important disclaimer. This webinar is supported by Septodont, a company that I deeply appreciated, and I really appreciate this invitation. This is the second or third webinar that I have been working with Septodont, and is really wonderful. So this is the agenda where we are going. I have a couple of slides. If you attended previous webinars, you know, probably the first 10 minutes of this lecture is something that you already hear, but I need to say that again. Some general facts about coronavirus, very short and to the point. A couple of slides about the clinical course, the roads of transmission, which is important for this webinar, because if we really want to understand how critical is to include ITR or ART or whatever you want to call this two, we need to understand that the virus can be transmitted in the aerosols that we generate. We are going just to say a few words about infection control from the dental practice, just a brief discussion about aerosol generating procedures, and then finally, probably the main core, the heart of this presentation is non-aerosol generating procedures and how they are pretty significant during these times of the coronavirus pandemic. So let's go with general facts. This is a good time if you want to stop and go to the restroom. You can come back. You probably know it's only 2 slides about this. So this is not a coronavirus webinar. I think so we are all tired of open the emails, open the news, watching TV, and every single conversation is around the coronavirus. So I just limited that to 2 slides, but I call this the bathroom break. So you need to go to the bathroom. This is a good time. So 2 slides. General facts. I can imagine it by now, you know, July 1st, 2020, I can imagine if you don't know anything about this. So the term coronavirus refers to a large group of viruses. They affect humans, mammals, and also birds. You know why the name coronavirus is because of spiky projections on the surface. There are hundreds or maybe more than hundreds coronaviruses, but we know that 7 can affect humans. And out of the 7, 4 human coronavirus can cause mild cold or flu-like symptoms. And then out of the 7, we know 3 that they can actually bring more serious risk to us. One of the 3 is obviously the SARS-CoV-2, the one who is associated with the COVID-19. So the second slide is, you know, the little brother of the SARS-CoV-2 is the SARS-CoV-1, which is associated with a severe acute respiratory syndrome. If you remember, some of you may be not born in 2002, but I was born. In 2002, the SARS-CoV-1 was associated with this acute severe respiratory syndrome. And in 2002, it was an epidemic, more than 8,000 people. Imagine 8,000 people compared with the big brother is pretty much nothing. In 26 countries, and about 800 people die. We don't have any more cases. The other coronavirus who belong to the family, this is the middle brother, is the MERS-CoV, which is associated with the Middle East Respiratory Syndrome. The first case was reported, I believe, in 2011, 2012 in the Kingdom of Saudi Arabia. And then since 2012, about 27 countries have reported more than about 2,400 cases. And finally, the one who really changed our life, the SARS-CoV-2, which is associated obviously with the COVID-19. The first case was reported in China. We know that. And by July 1st, 2020, about 10.5 million people have been infected in the entire planet, and about 512,000 people die. 2 things about the clinical course. I can go pretty straight to the point here. As you know, the majority of the patients infected by the COVID-19, they present very mild symptoms. Important for us as a dentist that some of the patients, they actually will not have any symptoms. So in some way, we can have a patient sitting in the chair and that patient is not having any symptoms, no fever, but the patient can be infected. So the most common symptoms, you know that, I don't know how many million times you read about that. The less common symptoms include loss of smell, taste, headaches, and diarrhea. The median time for symptom onset to the development of pneumonia, which is the severe COVID-19, is about 5 days. The second slide about the clinical course, the incubation for SARS-CoV-2 is about 2 to 14 days. The onset of the duration of the viral shedding on the period of infection for COVID-19 is not very clear. So we dentists and our staff members, we need to assume that every single patient who is sitting in the chair is capable of the transmission regardless of the symptoms. And we know that older people, older than 65, they are more at more risk of being affected by the coronavirus in a more severe way. So COVID-19 is primarily a respiratory infection that can affect different systems. Okay, the routes of transmission, I have 10 slides. Some of the slides I will go very quick, but this is important to start to connect this webinar with the non-restorative or the non-aerosol generating techniques that we can use and why that is important. So I always believe that it's worth it to spend a few minutes about the routes of transmission of SARS-CoV-2, because in that way, that's the justification to think out of the box when we have a patient with an occlusal lesion in tooth number. I mean, I'm not going to use numbers because you are maybe in a different part of the world and you use a different way to designate the teeth. So imagine you have a occlusal caries in the first right maxillary molar. And if we understand the route of transmission of COVID-19, then we also are going to acknowledge, or we are going to be fully aware that using aerosol generating procedures could be potentially a risk. So only 10 slides, but I will go quick here. So SARS-CoV-2 is mainly transmitted through droplets, small droplets, about 5 to 10 microns. So there is a person-to-person transmission. The droplets containing the virus can fly away from my mouth when I cough, when I sneeze, and when I talk. The droplets can travel usually a distance of about 2 meters. Sometimes could be more than that. That's what we call, or that's the reason why we need to keep this social distance. And this is an airborne transmission. So it's transmitted to these small droplets. So as you can imagine, these small droplets, when they are really little, less than 5 microns, they can be suspended on the air. And we can generate these small particles when we are using aerosols in dentistry. And they may remain in the air for a long period of time. That's the reason that we need to practice aerosol generating procedures precautions. And we all know that. We all dentists know that. So why aerosols? Yes, in dentistry, we generate aerosols. Interesting, just the last sentence. The aerosols, about 90% of the aerosol that we generate in dentistry when we use the high speed or when we use the Cavitron, they are smaller than 10 microns. So they are pretty small aerosols, and they can travel about 2 feet away from the source. And this is a graphic that you may already saw in these different publications, but this is to give you an idea how the small droplets, they can travel for a long distance. Some authors believe that they can travel even 6 meters away from you. I want to point to one article that I mentioned in a couple of my webinars before, but I'm not going into many details, but I want to invite you someday when you don't have anything to do, when you are alone at home, and you already cleaned the kitchen, you mopped the floor, you did everything that you can imagine, and then you don't have anything to do. So if we don't have anything to do, I will invite you to look for these articles. For this article, which interesting, it was published in the Journal of the American Dental Association in 2004. So yes, 16 years ago. But the main author, Dr. Molinari, is still one of the worldwide experts in bio control and control of infections in dentistry. But listen, this is interesting because this article came outside when SARS was kind of floating around. So this is about 2004. And at that time, some questions about the potential of a spread of infections from the aerosols. So there is no question that, and this is from Dr. Molinari's study, that the fluids in the mouth are grossly contaminated with bacteria and viruses. And the next one is interesting. This is the table 2 from this article. And Dr. Molinari concludes that the tooth preparation with the air high speed, there is a minimal airborne contamination if a rubber dam is used. So in 2004, look how this statement can be also applied in 2020 when we are dealing with the old brother of the SARS-CoV-1, which is the SARS-CoV-2. And the use of the air water syringe indicate that could be also an airborne contamination is nearly equal to the ultrasonic scalars. And finally, the use of ultrasonic scalars is one of the greatest sources of aerosol contamination. So it's recommended, and this is actually part of the article of Dr. Molinari in 2004, it recommended the use of high volume evacuators to reduce the potential airborne transmission of SARS-CoV-1 when this article was published. One more article, which I already presented a couple of times. This is just to tell you how important it is to use the face mask. I know in some countries in the world, the use of the face mask seems to be a little bit like not all the population is really agree with put the face mask, but look at this. If you say stay healthy with a mask and without a mask, it really make a difference. And you can see in the picture on the left side, that's if you say stay healthy with no mask, you can see all these small droplets that can travel about 2 meters. And if you say stay healthy with a mask, you limited more than 98% of these small droplets that they can travel outside. So my friends and my colleagues, there is no question that the use of the face mask is a fundamental component of the way, that's a personal responsibility that we have as humans to avoid the spread of the virus. And it's probably the most effective. So this is also an article published in 2008. When you cough, you expel particles that they can travel about 3 meters and they can stay suspended in the air for several minutes. For how long the SARS-CoV-2 can stay in a surface? Well, there are different studies that they look at that, but I will say that, and again, you may actually know more than me, but this article published in the New England Journal of Medicine a couple of days ago, they conclude that the virus can stay in about 1.1 hours in different surfaces, a little bit more stable on plastic and stainless steel. And finally, probably the article that I believe is the most critical article, and I feel chills when I look at this article because it's one of the best editorials in the New England Journal of Medicine the last 6 months, if not the best editorial. The title is Asymptomatic Transmission, the Achilles heel of the current strategies. That is why we actually have problems containing SARS-CoV-2, and we contain SARS-CoV-1 pretty quick. The reason is the asymptomatic transmission of the virus. So that means that people can be transferring the virus and they can be absolutely asymptomatic. What is the implication for us as a dentist? The implication for us as a dentist is we need to assume that every single patient who is in the chair, regardless of if the patient, seems to be absolutely healthy, run 3 marathons per day, we need to assume that that patient is transferring, is maybe affected by the virus, is maybe an asymptomatic patient, and that patient could be the source of the transmission. So now when we talk in a few minutes about non-aerosol and aerosol generating procedures, keep in mind that that patient that you are ready to grab the high speed to work in your class 1 filling or whatever you are going to use the high speed, keep in mind that you are going to generate aerosols, and there is a potential that that patient is an asymptomatic and the patient may be infected. So that's an important, in this article is quite important in that perspective. That's it. Let's go into a few slides about infection control. I have a whole lecture about this, but obviously I'm not going in the whole lecture about this, just a few things. And I'm going to concentrate in some infection control during the appointment. As you can imagine, they are infection control pre-appointment, during the appointment, and post-appointment. But because we are talking today about non-restorative, non-aerosol generating procedures, I'm going to just concentrate in during appointment considerations. So during appointment considerations, obviously we need to do standard precautions, which means hand hygiene, and obviously we need to use the face mask. We need to try to avoid production of aerosols. That's easy to say. I can say that in a minute. Avoid the production of aerosols. That's pretty easy to do it, but it's not always possible. But as much as we can, we, especially now during the time that in some places of the world we are seeing the most number of cases, as much as we can, we need to avoid the production of aerosols. Now we need to use the forehand dentistry. We have volume evacuation. We need to allow time for aerosols to settle following the procedure if you decide to use aerosols. And we need to avoid as much as possible paper around our office. And it's a common sense to have all the supplies and the use of rubber dam or other isolation techniques and the full face shield and covering the head, the gowns, and the N95 and everything else. If you are still not decide what is an aerosol generating procedure, these are the aerosol generating procedures definition by the United States Department of Labor and the Occupational Safety and Health Administration. They define these 4 as the use of the high speed, the low speed, the ultrasonic scalars, and the use of the air water syringe as aerosol generating procedures. And we need to, every time that we grab a high speed or a low speed, we need to think about that as a high aerosol generating procedure. So we need to keep in mind that when we are deciding to provide treatment to our patients. I love this slide. I really like it because, and this is a good kind of appetizer for what is coming in a few minutes when we talk about the non-restorative techniques and how we can use Biodentine and how Biodentine will fit very well in this option. But this slide is a great slide. It's a slide to define the risk that we are exposed when we work in an office, especially during these days. So there is a medium risk. Obviously, let me back up a little bit. It's a lower risk if you are sitting in an office all day long. That's a lower risk. So your office manager or somebody who is sitting in an office and is not exposed to aerosols, that's a lower risk. It's a medium risk if you are providing dental care not involving aerosols. So that's the importance of these 2 techniques that we are going to talk in a few minutes. That's a medium risk. If you can avoid the generation of aerosols, you really are decreasing the potential that you get infected, or you can infect your staff members, or the next patient can get infected. Now, definitely it's a high risk if we decide to perform aerosol generating procedures. So if we decide to use the high speed or the low speed, it's a consideration of high risk procedure. So we need to do all the precautions that they are according to the country that you are. Here in the United States, we follow the CDC guidelines, which basically we decide to generate aerosols. In my practice, I need to have an N95 mask, and then over the N95, I need to have a level 3 surgical mask, and then I need to have the face shield. So that's a high risk generating procedure. Now, in terms of what we are going to do, if we are medium or high, we need to have the standard precautions, the contact precautions, and the droplet precautions that we are going to talk about that in a few minutes. So if definitely an aerosol generated procedure is the next option, if you decide, okay, I'm going to grab the highest speed and I'm going to grab the lowest speed, if that is your option and that's your clinical judgment, you know, nobody can tell you when yes or when not. That's you sitting in the chair in your dental office. But if you decide to use an aerosol, which is one of the 4, then obviously there are a couple of options that you have. There are some suggestions to use a mouth rinse. There is no hard evidence that using the mouth rinse will decrease the potential of transmission of the virus, but at least in theory, that sounds a good technique. Just use the mouth rinse, and there are different options. Now, there is no question that the use of rubber dam, and if you decide to use an aerosol procedure, the use of the rubber dam or other alternatives. I'm a pediatric dentist. If you can imagine, sometimes in some kids, as soon as they see the rubber dam, which means they cry. And so as soon as they know, oh my God, as soon as I tell my assistant, okay, I need the clamp, it's like a clamp means I need to cry. So sometimes in our specialty, it's not easy. And if you work with adults, well, with adults, however, some adults also complain about that. So I use other alternatives for isolations like dry shield or Isolite. There are other alternatives in the market who are a little bit more friendly. Believe me, as a pediatric dentist, in trying to put a rubber dam in a 3-year-old is not easy. And it's like immediately that's a trigger to start to cry. Now, if you decide to use an aerosol generating procedures, we prefer to use the high volume evacuators, not the saliva ejectors. These usually are coming with your dental unit. And so that means that you need to be working with someone else, your assistant, who is the one who is going to be suctioning that. Now, if a non-aerosol generated procedure is the next option, and I hope that you really think about this, especially during these times. I don't know how long it will take to have an available vaccination and we can move out of this situation, which really has been very difficult for everybody. I call every day my parents, and I hope that you do the same. My mom, my dad, you know, they are in the 80s, and I always, you know, pray to God that they will be fine. So I hope that we find that vaccination as soon as possible, because that will make a difference, especially for the patients who are in a high risk. So not using aerosol, I think that's a good option, you know, or reducing, not necessarily stop to use aerosols, but you can decrease the use of aerosols. So for that, we have some options. We have the minimally invasive restorative dentistry. We are going to talk about that in a minute. We have the option of SDF or silver diamine. This lecture is not about silver diamine. We have the SMART technique, which is the combination of the silver diamine with, you can use Biodentine or you can use glass ionomer. And we have the ATR and the ITR, which we are going to talk about that. And there are other non-aerosol generating procedures like a resin infiltration. And this webinar is not about that. So we are going to start, and we are in the center of our webinar. So I hope that you are still awake. So this time is not to go to the restroom. Honestly, you need to hold it. Just hold it for about 25 minutes, which is what is still time to complete the webinar. So these are the practical guidelines on non-restorative. This is basically, you don't take anything. You don't take a excavator, you don't use any hand instrument, you don't take the highest speed. And this is sound science. And I'm not going into too many details here, because it will be a completely topic for a different seminar. But this is coming from a publication that I love it in JADA in 2018 about the evidence-based clinical practice guidelines on non-restorative treatment for caries lesions. That means that you don't take anything. You don't take any hand instrument. You don't use anything. You just look and decide, okay, I think so this is a good case for, and then these are the options. So the option is to arrest cavitated. Listen to this. When I went to dental school in the 80s, I can't imagine this slide. This slide will be almost, I don't know, they will probably expel me from the dental school if I will say something like this. You know, in the 80s, nobody will say, oh, these are the options to arrest cavitated coronal caries lesions. But in the 21st century, we know a lot more about decay. So this is absolutely perfect. So to arrest cavitated coronal caries lesions on primary and permanent teeth, what is the best option? Silver diamine, silver nitrate, or sealants? So based on this report, the best option is silver diamine. So that means that you have a cavitated caries lesion, you don't want to take any instrument, you don't want to do anything, you just want to put something there. You can use silver diamine at 38%. If you want to have more time about this, if you want to read it, it's free to the public. You can go to the JADA website. It was published. The main author is Dr. Slayton. It was published in 2018. So you can go ahead and read because they discuss a lot more things than just cavitated coronal caries. They also talk about interproximal caries and facial caries. But for this webinar, we are just going to leave it like that. Now, practical guidelines on restorative treatment for caries lesions using or minimizing the use of aerosols, or definitely not using aerosols. So this is really the center of my webinar. This is really the heart of the webinar. I think so. If you are following, I am not against the use of aerosols, and I need to be clear on that. I am not just saying never use aerosols. And I know in some places of the world, I need to be careful to say that because I know if you are in Asia, or you are in Europe, or you are in Africa, or you are in America, in some countries, they are really recommending, almost suggesting, or saying that you cannot use any aerosols. I think so, depending where you are. Here in America, we are trying to minimize the use of aerosols, but at the end, it's your clinical judgment. So my idea, this is my personal idea, is I'm going to minimize as much as I can the aerosols, but in some situations, I will definitely use either high speed or low speed. So we have the options of the ART, which is the atraumatic restorative treatment. We are going to talk a little bit more about that. Then we are going to say a few words about the SMART technique, and then the ITR, which is the interim therapeutic restoration. I think so this is a good point of my webinar to make sure that you understand the difference between ART and ITR. I know, believe me, I said this a million times and I still confuse. ART, sometimes I say ATR, sometimes I say TRA, but so I'm going to just say the whole technique: atraumatic restorative treatment and interim therapeutic restoration. So what is the difference? The difference is basically in atraumatic restorative treatment, you are, or I would say you are not. The idea is you are not including a follow-up with the patient. You are going to place the material with the idea that it's very unlikely that you are going to have the opportunity to follow the patient. So you are going to minimize the use of aerosols. In fact, you probably are only going to use some hand instruments. You are going to remove a little bit of the infected dentin and enamel, and we are going to go over that in a minute. You place the Biodentine, you wait 12 minutes, and then patient probably for X, Y, or Z reason, and I know it could be different reasons, will be difficult to follow up. Now the ITR, which is the same, the interim therapeutic restoration, as you can tell by the name, the idea is that you are going to provide a definitely treatment in a time of between a month to 6 months. Could be a little bit more, but that's kind of the frame. And in your mind, you are going to provide the treatment to that tooth with the idea that the patient will come back at some point to provide more definitely treatment. So let's start with the ART. A little bit about the historical perspective. So this was endorsed by the WHO as a means of restoring and preventing caries in population with little access to traditional dental care. In many countries around the world, practitioners provide treatment, as I know that for firsthand, in non-traditional settings that restrict restorative care to placement of provisional restoration. Because sometimes there is no opportunity to follow up care, ART is assumed as a definite restoration. So the restorative phase of ART is basically two components. One is sealing of caries prone to pits and fissures. That will be the ART sealant. And then the other one is restoration of cavitated dentin lesions, which is the ART restorations. So Biodentine is a very effective and biocompetitive alternative for the ART. Longitudinal studies have reported a high success rate for ART technique, especially in class 1 cavities. I think so that's important. when you are trying to use the ART technique in class 2 cavities, you need to be careful because the success rate really decreases. So for class 1, especially when you have all intact, all 4 walls, and we are going to see that in a few minutes, that's the perfect indication for the ART. However, the same success rate is not reported when the procedure is performed in cavities involving multiple surfaces. Large meta-analysis showed that the longevity rates for class 1 restorations are 95%, 93%, and 66% after 1, 2, and 3 years respectively. So definitely the success rate decline over time. You know, the success rate is close to 100% after 1 year if this is a class 1. If this is a class 2 and you decide to use any material, including, of course, Biodentine, in multi-surface restorations, ART, the success rate goes from 71% after 1 year, 62% after 2 years, and 3 years is about 31%. So it really decreases the chances that that restoration will survive. And you need to keep that in mind when you are doing that. You know, the ART publication from 1976 to 2020 really increased. In 1976, just a couple of studies, and really explode in the last 10 years. If you want, again, if you are in a Sunday and you don't have anything to do and you already cleaned the floor, you did everything that you can imagine at home, this is probably the best reference when you want to learn more about ART. It was published by Cochrane, and you know Cochrane is probably the most widely used data repository in best evidence dentistry and best evidence medicine. It's really unbelievable. And there is a Cochrane review about atraumatic restorative treatment compared with conventional restorative treatment for the management of dental caries. This is an absolutely iconic diamond paper that is very appropriate for these times of the coronavirus. So they look at the success. So they compare doing the ART, they compare that with the conventional treatment, which is drill and fill, and the use of high speed under local anesthesia. And they use different, and obviously they look at different materials, glass ionomer in different materials. So the goal of this the goal of this review was to compare ART compared with the conventional treatment for the treatment of primary and permanent teeth in children. I really will invite you to look. It's publicly available. You don't need to pay for that. And this is the conclusion. This is interesting. The conclusion was, and I'm just giving you a very quick summary, there is a low quality evidence that suggests that ART may be have a higher risk of restoration failure than conventional treatment. So that suggests that when you really are just focused in ART, you are not looking in a potential follow-up of the patient, definitely there is no question that there is a potential risk of that. And we knew that for the previous slide when I talk about some meta-analysis. Now, the risk is higher if you use the ART technique for class 2, and the risk is lower when you use the ART technique for class 1. So that really makes a big difference. Now, it was also an article published in Pediatric Dentistry a couple of years ago, and looking at the success of the ART, they used glass ionomer, and they found that the overall success rate at the 6 months follow-up was 69 and 83%. 83% for class 1 and 69 for class 2. And after 12 months was 56% for class 2 and 86%. So the point is, if you decide and you think that you cannot follow that patient, it's impossible to provide follow-up, definitely you need to try to concentrate towards class 1 because you know that that probably will give you the higher success. Just a few sentences about the SMART technique, which is the silver modified atraumatic restorative technique, which we have been using this a lot here in our hospital, which basically the caries lesion is treated first with silver diamine, and then after you do the silver diamine, it's almost like a sandwich technique. You treat that with silver diamine, and then you restore that using GI, resin modified glass ionomers, or Biodentine. And it is interesting, in vitro studies confirm that the use of silver diamine is not going to affect the bone strain between the GI and the dentin, or between the Biodentine and the dentin. So basically, you see the caries lesion, you can excavate using a hand instrument, then you use the GI, the reinforced resin modified glass ionomers, or you can use Biodentine. Now, the interim therapeutic restoration, remember, if it's not an opportunity to follow up, please try to keep that in class 1. But if there is an opportunity to follow up, then we call that the ITR, the interim therapeutic restoration, which is used to restore, arrest, or prevent the progression of caries lesions in young patients and cooperative patients or patients with special healthcare needs when traditional cavity preparation is not feasible during the coronavirus time or need to be postponed, or you try to minimize as much as you can the use of aerosols. So ITR is a non-aerosol generating procedure. If you don't mind, let me say something else. It's not just only non-aerosol, it's a minimize the use of aerosols, because as you are going to see in a few minutes, sometimes we can use a low speed to just go very gentle and remove some of that infected dentin. And obviously we minimize that, and then we can use Biodentine. So the interim therapeutic restoration may be used for a stepwise excavation in kids, also in adults with multiple caries lesion prior to a definite restoration. Remember, if you are thinking about ITR, it's because you believe that you are going to provide a definitely treatment for that tooth in a time of about 6 months. You can use ITR, and I use that all the time in my office when a tooth is coming and is challenged to provide isolation. You know, in a child, you tell the child not to move the tongue when you are doing isolation, and then the child, obviously, he will do the opposite. He will move the tongue. So sometimes isolation is a challenge. ITR can be also used to reduce the levels of carcinogenic bacteria. So how is the technique? So you remove the caries using a hand instrument, which is non-aerosol, or you can use rotary instruments, low speed with caution not to expose the pulp. I think so the critical component here is the seal. When you use the Biodentine material, you need to make sure, and we are going into the examples in a minute, you need to make sure that you seal that, and there is no way that is going to happen a leakage. Because if it's some leakage in the restoration, that is one of the factors that is going probably to play against you and is going to affect the prognosis of that tooth. So following the preparation, you can use different options of material, including Biodentine. How is the technique? So, you know, the teeth treated with the ITR should be managed with more definite restoration within 6 months, as I said before. And the increased success of the ITR was detected in one surface or two small surface restorations. So you can keep it for a class 2 if it's a small surface restoration. But definitely, if this is a big class 2 restoration, that plays against you. And then you can use the Biodentine. Following the preparation, and I put preparation between a quotation, means that you go with the hand excavator and then you can place the Biodentine. So let's go and talk about Biodentine. I started to use Biodentine a few years ago with excellent results. And I will share, we are about 20 minutes to finish the webinar, 15 to 20 minutes. So we are going to concentrate in Biodentine and how Biodentine will be a perfect material for ITR, or interim therapeutic restoration, or ART, atraumatic restorative treatment, assuming that you are not really contemplating the option of see the patient in a follow-up. So let's go and say, so Biodentine provides the physical properties of the GI as early as 1 hour, and over time, the properties of Biodentine are very similar to the sound dentin. That's the reason that we consider Biodentine as a dentin replacement material, and it's the first and the only dentin replacement available that we have. Bio can replace it in both the crown and the root without any preliminary conditioning of the mineral tissues, which in my opinion, that's a big advantage of Biodentine compared with other materials that we can use, because you don't need to have any preliminary condition of the tissues, which means you can save some time. So Biodentine allows for composite restorations in the same visit if you decide to put a composite in the same visit. And Biodentine contains a high purity monomer-free mineral ingredients and is highly biocompatible. Biodentine is not toxic to the pulp cells. That's the reason we are going to learn the indications in a few minutes. It's a great material for direct pulp cap, and we are going to see that. So Biodentine creates the favorable conditions for maintenance of the pulp vitality. This is one of the big advantages of Biodentine compared with other materials available in the market, such as, you know, GI or resin modified glass ionomers. The initial setting time is about 12 minutes. And the 12 minutes of Biodentine starts from the time that you start the mix. So Biodentine creates a high alkaline environment. The pH of Biodentine is about 10 to 12, which is antimicrobial. And these are the indications. So permanent dentin restorations under composites. And the one in yellow is the one that is a good option during these days of the pandemic, the temporary dentin enamel restorations, ITR or ART. Remember, please remember, if you're still awake here, look at my eye, remember that if you are thinking that you cannot follow the patient, that will be the ART, but I hope that you can provide some follow-up and more definite restoration that you can put over Biodentin. So Biodentin can be used in deep and large coronal caries lesions, restoration of cervical radicular lesions, and pulp cap and pulpotomies. I am not really the expert. This is more my endo colleagues, the endodontist. Remember, I'm a pediatric dentist, but Biodentin is an excellent material for repair of root perforation, repair of furcation perforation, repair of perforated internal resorptions, repair of external resorptions, apexifications, and root end filling and endodontic retrograde filling. A little bit about the formulation. I don't want to really spend a lot of time here. You can find that in the Septodont website. But if you are interested to know what is the composition of Biodentin, so I will just have a couple of slides about that. So Biodentin is a calcium silicate cement that stimulates secondary dentin formation. It is composed basically by a powder and a liquid that we are going to mix it. The powder component is tricalcium silicate, calcium carbonate, decalcium silicate, calcium oxide, and iron oxide. And the liquid is a hydrosoluble polymer and calcium chloride. So after mixing, this calcium silicate, which is in the powder, reacts with the water, and that will move into calcium hydroxyl and silicate ions. A little bit more about this. The resulting calcium hydroxide, after you mix that, will move the pH to 12, which is a great pH. It's an antibacterial, while the calcium silicate hydrates gels polymerize over time to form a very rigid structure. It takes about 12 minutes. And then later, the calcium silicate interacts for the phosphate ions in the saliva to form apatite deposit that increase the sealing ability. It's an excellent sealing and decreasing the leakage. Interesting, Biodentin promotes the pulpa healing by increasing cell proliferation, migration adhesion, and RNA expression of chemokines. It's highly biocompatible and non-cytotoxic. So comparing with other materials, Biodentin has a higher compression strength, lower porosity, shorter setting times, and better color stability. Why that shorter setting time, which is, as I said many times, 12 minutes, is because the presence of the calcium chloride in the liquid and the calcium carbonate in the powder. It was an excellent article that I will invite published in Pediatric Dentistry about what is the effect of Biodentin or how Biodentin interacts with the overlying material. So if you are deciding to put Biodentin and then later on you decide to put a stainless steel crown, or you decide to place a resin modifying glass ionomer, or you decide to place a composite, they evaluate what is the effect of the overlying materials over Biodentin. And the conclusion is there is not, and I love this, the overlying material showing no effect in the Biodentin final set. So whatever you are going to use, either you are going to put that material immediately or you are going to wait 6 months to put the material, that overlying material that you are going to place over the Biodentin is not going to affect the final Biodentin set. This is also an article published. I love to, when I talk about materials, I love to look for research to really help me to understand if all these nice properties that you can look at the website, if they are true or not. This article was also published in Pediatric Dentistry, September of 2017. And the idea of this article was to evaluate the clinical and radiographic outcomes of Biodentin as a substitute, as a dentin substitute for indirect pulp cap in primary teeth. And this is interesting. The conclusion was combined clinical and radiographic success rate were 98% for Biodentin and 95% for light activated calcium hydroxide, which means Biodentin has an excellent success rate when you are using that as an indirect pulp cap. Let's go a little bit about Biodentin mixing instructions. This webinar is going to be available, and also if you want to have my PowerPoint, I already passed this PowerPoint to Septodont, but you can email me and I can email you the PowerPoint if you want it. I will give you my email in a few minutes. The mixing instruction is something that I learned, and I want to emphasize that this is important when you use Biodentin to follow the instructions. and you can read it here better than me. It's also coming when you have the material set. You can read the instructions. You basically open the capsule, and then you put some drops. You open the capsule, and then you put some drops of the liquid, and then you close the capsule, and then you put that in a mixing device for about 30 seconds, and then you take that using instrument which is provided, or you can use an amalgam carrier. So this is the material. As soon as I open the box, you can see the powder is there, and then the kit will have this. This is the liquid. You need to be careful. You just detach one of these single dose container of liquid. You're very gentle. You take away the top, and then you force the liquid down into the container, and then you pour about 5 drops from the single dose container into the capsule, and then you close the capsule and you put that into the mixing device, whatever you have in your office, for about 30 seconds. If you need that a little bit thicker, then you can wait a little bit longer. So depending, you can learn at your own, depending how thicker you like the material, you can increase or decrease the mixing time. What I use in my office, and I will show you in a minute, I use a spatula, or you can use an amalgam carrier. So this is the Biodentine when we are in ITR or ITR or ATR. So for immediate enamel dentin restorations, I cannot say more about this. Obviously, when you are going to use Biodentine or any other dental material, you need to assess the pulp vitality. That means that you need to have a good history. You need to make sure that there's no spontaneous pain. You need to make sure that that patient is not waking up in the middle of the night with pain. You need to make sure that they are not radiographic changes that they indicate that you have a necrotic pulp. That's your clinical knowledge that you need to apply at the time that you decide to use Biodentine or any other material. So I always put that red arrow because my friend, my colleague, you are still there, and it's only about 8 minutes to finish this webinar. Please be sure that you have a good clinical evaluation of that patient, so you make sure that that tooth is a good indicator for an immediate enamel dentin restoration. So you isolate, you remove the infected enamel or dentin with a round burr, slow, or hand excavator, leaving some affected dentin. Then, if this is a class 2, small class 2, you need to adapt a matrix to the tooth, and then you insert Biodentine and you avoid trapping some air bubbles, and then you wait until the end of the setting time, which is about 12 minutes. Remember that you start to count the 12 minutes from the time that you put the capsule into the mix, and as soon as done, you start to count the 12 minutes. So 12 minutes, I know, I'm a clinician, 12 minutes can sound a long time, but by the time that you take away the capsule from the mixer, you open it up, you put it in the amalgam carrier or whatever you use, believe me, it's about 3 to 4 or 5 minutes. And then when you put that, by the time that you put that in the material, you are close to the 12 minutes. And then you put your permanent restoration, which is a composite, amalgam, stainless steel crown, or whatever. Now, remember that in the previous article, and there are several articles about that, the material that you use is not going to affect the setting of the Biodentine. So Biodentine is also compatible with all types of different bonding systems. So you have something like this, you have that too. I use, this is for this particular situation, it's an ITR. So I just use a low speed instrument and hand instruments. I remove the decay, I place my matrix, and then I place the material, and then over the material, I place a composite. My idea is to follow this patient in 6 months. Or situation like this is a patient that I saw recently in my office. I hand excavated that. I use the high speed. Obviously, if I decide to use aerosols, I need to use my N95, and I used to use a surgical mask over that, and I use Biodentine over that after I hand excavated that lesions. And then after I wait the 12 minutes, I place my definite restoration. So Biodentine can be also used as a non-immediate enamel restorations. Again, you need to assess the pulp vitality. You do the isolation, remove infected enamel of dentin with a round burr or hand excavator. You can leave the affected dentin. You adapt a matrix if you are using a class 2. Then you insert the Biodentine, and then you wait until the end of the setting time, which is about 12 minutes, as I said many times. And then you check the occlusion of that. And then within 1 week or 6 months of that, you prepare the cavity. You can leave the remaining biodentin and you can consider that as sound artificial dentin. I love that. I can imagine in the 80s when I was in dental school saying artificial dentin. I mean, I can imagine that. Artificial dentin. So if you decide to use this, the non-immediate enamel restoration, you just put the material and then you just wait. You can wait a month, you can wait whatever. But the idea is you can take this up to 6 months. So you can hand excavate this and then you prepare, you wait the 12 minutes. Then you can use a hand instrument to place that material there. Then you can clean it up a little bit. You can put more material and then you can leave it there. And you can wait, a couple of months until you decide, okay, it's time. And you can leave the material as your artificial dentin. So biodentin will have an excellent biocompatibility with that dentin and excellent biocompatibility with the pulp. There are other clinical indications of biodentin that I need to say, not just only for ART or ITR. Biodentin can be also used as a protected liner, and obviously you need to assess the pulp vitality. So as you know, a protected liner is a thin applied liquid placed on the pulpal surface of a deep cavity preparation. The idea is to cover the exposed dentin tubules and act as a protective barrier between the restorative material and the cement. The idea of protecting liner is to minimize injury to the pulp. That promotes the pulp tissue healing and minimize the postoperatory sensitivity. So you isolate, you remove the caries lesion, you prepare biodentin, and then you place biodentin directly into the pulp floor. You wait for 12 minutes, and then you can perform the immediate restoration. You can also use for indirect pulp cap. So indirect pulp cap, again, you need to assess the pulp vitality. That's a tooth with a deep caries lesions, very close to the pulp, but without any signs and symptoms of pulp degeneration. The caries surrounding to the pulp is left, so you intentionally leave some caries in the cavity, and you don't want to have any. You do that because you want to avoid the pulp exposure, and then the biodentin is placed over the remaining caries dentin to stimulate the healing and the repair, and then you check for a good seal to prevent micro leakage, and then obviously you perform the immediate restoration. Biodentin is an excellent material for direct pulp cap. I have been using this. Here at Riley, we see a significant amount of patients with trauma, dental alveolar trauma. So as a direct pulp cap material is excellent. Remember, when a pinpoint mechanical exposure of the pulp, no caries exposure to the pulp, is encountered during a cavity preparation or following a traumatic injury, biodentin can be placed in contact with the pulp. So you isolate. If it's some bleeding of the pulp, you try to use with cotton pellets, whatever you want it to cause hemostasis, and then you prepare the biodentin, and you can place the biodentin directly into the exposed pulp. And then you perform the immediate restoration or not immediate, whatever you want to do. So this is a patient with a class 2 fracture, class 3, I'm sorry, with pulp exposure. This is the picture that I took. You can see the pulp. So this is a trauma exposed to the pulp. Perfect indication for biodentin, for direct pulp cap. So we isolate, we clean that pulp, we obtain hemostasis, then we place the biodentin, we wait the 12 minutes, and then we place the final restoration. You can also place a final restoration with the idea that the patient will come back to have a final restoration. I'm also using biodentin for pulpotomies. So remember, in a pulpotomy is when you have an extensive caries but no evidence of radicular pathology. So you isolate, you remove the infected enamel and dentin with a round burr or hand excavator. You gain access to the pulp chamber and you clean out the pulp, which is located in the pulp chamber. If there is some bleeding, you provide some hemostasis before you apply biodentin, and then you adapt a matrix, and then you place the biodentin directly into the pulp chamber. And again, you need to keep that in mind to wait for 12 minutes. And then you do, this is a patient that we saw recently here at the hospital, that's the preparation. Now, obviously, this is not an ART or ITR because we use aerosol generating procedures. So if we are doing that, we have the rubber dam, high evacuation, we place the N95 over the N95 surgical level mask, and then we place a face shield, and then we use the highest speed. We prepare the biodentin, and then we place the biodentin directly in contact with the pulp. We wait the 12 minutes, and then Over that, we place the crowns. So we place the definitely treatment using the Biodentine. Okay, with this, I took a little bit more, about 5 to 7 minutes more. I really want to thank everybody who stay, who listened this whole webinar. I hope that you learned something. I think so. During these unprecedented times, we need to really think out of the box. And I hope that with this webinar help you to think out of the box, other alternatives, and definitely Biodentine is an excellent alternative. I already sent the link, so Septodont will make sure that they will make access to the recording of this webinar. They also can give you the PowerPoint, but if you want to have the PowerPoint also, I can send you this PowerPoint if you send me an email to the email that you see there. With this, Emily, I want to say thank you so much for the invitation. I hope that this is not the only invitation, and I hope that you are going to invite me for other sessions. And saying that, I can take some questions if there are some questions. But thank you so much, Emily.
Thank you to you. Thank you for this great presentation and lecture. And yes, there are lots of questions. First, some questions about the mixing of Biodentine, maybe to clarify. So for example, how about hand mixing Biodentine? Will the properties be affected?
Yeah, you can use hand mix. Yes, that's an excellent question. You can hand mix, like we know, as a dentist, we have been hand mixing for many years. You can do it. Basically you take the capsule, you open the capsule, you see the powder, you put the 5 drops, and then you move all the material out and you put that over a hard surface, and then you can mix that. Obviously, you need to mix it until you find the perfect texture that is the texture that will allow you to put it in an amalgam carrier, for example, to transfer that to the tooth. Or you can use a spatula to transfer that to the tooth. That's a good question. Thank you, Emily. Good question.
Another one, do you etch and bond Biodentine 2 before placing composite?
Excellent question. If you are placing Biodentine as a liner, or you are placing Biodentine as an indirect pulp cap, or you are using Biodentine as a direct pulp cap, you place the material, you wear for 12 months, for 12 months, oh my God, for 12 hours, for 12 minutes, for 12, my brain is starting to be affected. So I need to take a vacation time. So you wear for 12 minutes, and then you etch, you bond, and you place the composite. Yeah, you do that. You do that. And as I said before, research shows that that is not going to affect the physical properties of Biodentine. So yeah, you do that. Good question. 2 excellent questions that I will incorporate that on my presentation.
So we go on. Do you give antibiotics when you do direct pulp capping?
No. Usually no. We don't provide. And if we are, remember, direct pulp cap, and I need to say this, I know, my British accent. I know my accent is not British, but I believe it's British. I need to say no, we don't prescribe antibiotics. Remember, direct pulp cap is indicated when you have a mechanical exposure of the pulp. Mechanical means that you are using a high speed and the patient move or the patient bite, and then you expose that pulp, or you have a traumatic exposure of the pulp. Direct pulp cap is not indicated for pulp exposures because dental caries. If that happened, my friends, if you are excavating, and then you expose the pulp, then you need to move into a pulpotomy if that tooth is a good candidate for a pulpotomy. And good candidate means that they are not signs and symptoms that will contraindicate a pulpotomy, because you don't want to end up doing a pulpotomy in a tooth that is reflecting signs and symptoms of irreversible pulpitis. So that's a different story, because irreversible pulpitis means that you will need to move into pulpectomy and root canal. So I know this is a long answer, but we don't prescribe antibiotics.
In case of pulp exposure, do you have any special guidelines about size or time or pulp exposure?
No, if you have an exposure of the pulp, a mechanical exposure, usually it's a pinpoint exposure, it's a tiny one. No, you just place, you clean that, you can irrigate with water or saline solution, and then over that you place the Biodentine. If this is a pulp exposure because trauma, you need to do that as quick as you can, and then you place the material, as I show in the example, you place the Biodentine directly into the pulp.
We still continue with question. After you do the direct pulp capping, after how many days do you recall the patient for a follow-up restoration?
Okay, great question. Okay, if I do a direct pulp cap, it depends. I don't think so that it's a perfect answer, but generally speaking, if I do a direct pulp cap because trauma, which is the most common reason that we are doing direct pulp caps. So if I do that because trauma, I put the Biodentine, and then I wait the 12 minutes, and then over the Biodentine, I place what I call a Band-Aid restoration. Band-Aid restoration could be flowable composite, and then I will follow the patient first month. I will tell the patient to come back in a month, and then I will take a radiograph, make sure that the patient is still asymptomatic, and then maybe in 2 or 3 months, I will provide the definite restoration. However, some of my colleagues and myself sometimes, I can also provide the definite restoration in the same appointment. So I place the Biodentine, I wait the 12 minutes, and then I provide the definite restoration, and I don't place this Band-Aid restoration. And then obviously I need to follow the patient using the guidelines for dentoalveolar trauma, which, as you know, as well as me, that too deserves a follow-up in 4 weeks, 8 weeks, and then 6 months, because you need to make sure that that patient remains asymptomatic and you don't see any radiographic changes who indicate that this may be a more deep involvement of the pulp.
Is MTA and Biodentine the same? If not, what's the difference?
Good question. MTA and Biodentine are not the same, but they share pretty much the same indications. MTA is an excellent material, and pretty much the same indication that we discussed by Biodentine can be also used for MTA. And MTA, they are different, and several companies who produce MTA, which, you know, we pediatric dentists, we use the MTA. Probably one of the biggest differences is the setting time. The Biodentine setting time is shorter than the setting time of the MTA. There are other differences, which that will be a little bit outside of this webinar, but there are other differences. But to answer the question quick, they pretty much share the same indications, MTA and Biodentine, and they are not the same. Good question, Emily.
In case of class 2, Biodentine should be placed on pulp wall and axial wall.
Okay, good question. If you are doing a class 2 and you are doing an ATR or ART or ITR, so obviously you put your band or your matrix, T-band or whatever you use, and then you just fill that with the material. So you are placing the material in all the walls because you are filling that cavity with the material, with the idea, I hope, that you are going to see this patient in 6 months or less than 6 months, whatever you think is the next step, and then you remove the material. But if you are just placing Biodentine as a liner, you put over the pulpal floor. If you are placing Biodentine as a liner or an indirect pulp cap in the pulpal floor. I think so. One more question, Emily.
One more. Would IRM not be a longer lasting interim restorative option?
Can you repeat the question, Emily, please?
Would IRM not be a longer lasting interim restorative option?
Which material? I'm a little bit. It is the question about IRM, the material?
Yes.
No, definitely Biodentine or glass ionomer or resin modified glass ionomer. So MTA will give you much better in terms of strength than IRM. No question about that. Now, using IRM can be also used, but and again, this is my personal opinion, if you decide to use IRM, I hope that you are going to have the opportunity to follow up that patient, because that definitely will change the success rate after 1 year, 2 years, and 3 years. So definitely you use that material, you are looking more into ITR, interim therapeutic restoration. So Emily, I think so we have a great webinar. If you have more questions, I will be more than happy. You can send me an email. I always like to get emails from all over the world. More important, I hope that you still stay healthy. And Emily, saying this, if you have a few words before we say goodbye, I think so you are also going to put this webinar in YouTube, correct?
Yes, exactly. The webinar, you will have the opportunity to see it in replay on YouTube. Yes, exactly. So
Okay.
Thank you again. Lots of comments to say that it was a great presentation. So thank you again, Dr. Yepes, and have a good evening or a good day.
Yeah, have a good day. I know, Emily, you are in Paris, and I look at Paris every single day. And the day that I saw the tower is reopened, believe me, I have a big smile because it's such an iconic city affected by this like any other city in the world. But when I see that life is coming back to Paris, it's almost like a reference point that there is light at the end of this tunnel. I almost check Paris every single day to make sure that people is walking around, and that fills my spirit with optimism that we are going to see very soon the sun.
See you in Paris then. Thank you all. Thank you. Bye-bye.
Bye-bye.